Philip Orlander. I'm Professor of Medicine and Chief of Endocrinology at McGovern Medical School, University of Texas Health Science Center at Houston. Today, I'm going to be talking to you about diabesity. It's the diagnosis and treatment of obesity related to type 2 diabetes. I do not have any disclosures for this discussion. These are the objectives that I'd like to cover. I want to describe the recent level 1 evidence from randomized clinical trials directly comparing surgical versus non-surgical approaches to diabetes care, including among patients with a baseline BMI of less than 35 kilograms per meter squared. I'm going to discuss the weight-independent mechanisms mediating remission of type 2 diabetes after selected types of bariatric metabolic surgery, and identify new policy changes from the second Diabetes Surgical Summit and the American Diabetes Association advocating consideration of metabolic surgery to treat patients with inadequately controlled type 2 diabetes and a BMI as low as 30 and 27.5 in Asians. Obesity is a worldwide problem. This is a recent study looking at 195 different countries, over 68 million people. And you can see that over the last 25 years, there's been a dramatic increase across all the countries related to obesity, and in particular in North America. The new information from this study is looking at children. No other study before has demonstrated this dramatic increase in obesity in both boys and girls, which will predict new diabetes in younger individuals and then them living longer with that. Obesity has many different consequences. Looking at how obesity affects the fat cells, and the fat cells making a variety of pro-inflammatory metabolites, all related to insulin resistance and, of course, diabetes, which is a pretty linear relationship. But also associated with fatty liver disease. Fatty liver disease is now the most important hepatic problem now that we have treatment for hepatitis C, and is a growing reason for liver transplant. In addition, congestive heart failure and all cardiovascular morbidity is closely associated with obesity. And there's a long list of other metabolic and structural abnormalities associated with obesity that causes a significant amount of disability. But in this discussion, I'm going to be concentrating on the diabetes. In this graph from the same study, it shows that over the last 25 years, there's been a dramatic increase in death and morbidity, mostly associated with cardiovascular disease and indirectly with diabetes. So we understand that in trying to take care of the patients with diabetes, it's not just the patient in front of you, but you need to actually look at how your clinic is set up. How are you addressing the population problem? And this is new from the new standards of medical care in diabetes from the American Diabetes Association, published in January of 2018, looking at the focus of population health. We need to ensure that treatment decisions are timely and rely on evidence-based guidelines, and make a collaborative effort with the patients so that there is a sharing of information in terms of making those decisions. We want to align the approaches to diabetes management with a chronic care model, and this may be new to many practices, looking at more of a population base than on an individual patient. We want to look at the care systems we provide and make sure that we're delivering team-based care so we can be proactive in how we care for our patients. Efforts to assess the quality of diabetes care, looking at some of the information we can gather from our electronic health records, and building dashboards and scorecards for us and our colleagues so that we know that we're providing the best care to all of our patients. And that means redesigning the delivery system. And there are many efforts to do that in terms of medical homes. We want to stress the self-management of the patient. We want to look at different types of support for the patients and use our clinical information systems to be able to identify individuals that are at risk and proactively start making changes in their therapy rather than waiting for them to present with a problem. So we're looking at redesigning the healthcare system for some of our chronic diseases, and particularly in this case, diabetes. Now, 2/3 of the people with diabetes live in cities, and so it's important to look at how cities are constructed and deal with the problem of obesity in order to help with that. And there's an international effort on that. Cities Changing Diabetes is a brand new program. It is headed in Houston, which is one of the 8 cities internationally involved in this study, and looking at how to prevent diabetes. Looking at a variety of different ways, and over the next years we will be collecting information and being able to gather how we can do that. Because if looking at this curve, you can see that our current projection is that with increasing obesity, we will see an increasing rate of diabetes in our cities, such that in order to reduce the rate of diabetes by 10%, we need to reduce the rate of obesity by 25%. So this is obviously an ambitious goal. Now, over the last 20 years, we've seen a change in how diabetes even presents to the individual physician. So in the 1990s and before that, there certainly was a problem with obesity, and most of our patients with type 2 diabetes were clearly obese, although there were some that were not. And if you look at a subcategory of our patients with type 1 diabetes, they were typically thin. What we've seen over the last 25 years is that obesity seems to be overriding over all of the different sorts. This makes it somewhat difficult to make the diagnosis of what kind of diabetes the patient has, and also interferes with treatment. And I will show you how this occurs, because it's very much related to how we treat many of our patients with diabetes, especially with escalating doses of insulin in order to better control their blood sugar. This is a graph from the Diabetes Control and Complication trial. This was a landmark study looking at just young individuals with type 1 diabetes and randomizing them to very tightly controlled, sometimes using insulin pumps or multiple injections of insulin, or conventional control, so that the tightly controlled group had an average A1C of about 7% and the conventional group about 9%. The study was stopped after about 6 years when there was a dramatic reduction in microvascular complications in the group that was well controlled. During this period of time, they also looked at cardiovascular disease, but as these individuals were young, they typically only had diabetes without other comorbidities. The rates of cardiovascular disease was pretty low. There was a little bit of a difference, as you can see, between the curves, but they were small because the number of events were pretty tiny. Then both of these groups were followed without any intervention over the next 15 years or so. During that time, as you can see in the circle there, they had exactly the same glycohemoglobin. So the only difference between those groups was the glycohemoglobin in the first few years of the study. Subsequent to that, their blood sugars were the same. Yet you can see the dramatic division of those two curves, so that the group that had been well controlled had a much lower rate of cardiovascular disease, this occurring many years later. So this is what we call metabolic memory. So good control in the few years before that predicted the cardiovascular events occurring 4 to 7 years later. When these results are looked at a little bit closely, however, we see something different. In the group that was very well controlled, many of them required increasing doses of insulin. Those increasing doses of insulin led to increased weight. Those individuals who had excessive weight gain in the intensively treated group lost their protection from cardiovascular disease. And so again, you can see that insulin driving appetite in this population that didn't have a lot of the other comorbidities that we see with type 2 diabetes voided the benefits of the tight blood sugar control related specifically to cardiovascular disease. And this you can see in this curve here, where the group that had intensive insulin treatment and had better control, but if they had increased weight, they had a higher cardiovascular morbidity. So if we look at the spectrum of diabetes, at the far left side, we can see that individuals who have no insulin are typically going to be underweight. And there are relatively few of those, and the pure type 1 diabetics would fall into that category. But the majority of the patients we see have a combination of both insulin deficiency and insulin resistance. And there they have increasing weight with that. So as you look at the pathophysiology of diabetes, very early on, everybody has a significant amount of insulin resistance, as can be seen in that yellow line. And that insulin resistance maximizes for a period of time while the blood sugar is still normal and while the patient is actually making increasing doses of their own insulin. However, over time, the pancreas is unable to keep up with those required demands, and as the beta cell function starts to deteriorate a little bit, that's when diabetes occurs. So the insulin resistance is primary, but subsequent to that, in the body's attempt to keep up with that, the beta cell will eventually fail, and frank diabetes occurs at that point. This was eloquently shown by the study by DeFranzo at the University of Texas in San Antonio, showing that on the top curve, individuals having a glucose tolerance test, even within the normal glucose tolerance range, they were already starting to make more insulin. As they progressed along to impaired glucose tolerance, they continued to make excess amounts of insulin, but by the time they developed type 2 diabetes, their insulin secretion had dropped off substantially. But although it looked like they were making a lot more insulin, on the bottom curve, it shows that the change in insulin with the change in glucose after a glucose oral load was less. So they already were starting to lose beta cell function even within the normal glucose range. As they progressed along to impaired glucose tolerance, that worsened. And once they developed frank diabetes, they were basically not making any additional insulin for that hyperglycemia. So as long as the beta cell is healthy, it can keep up with the demands of the insulin resistance, as can be seen on this curve from Richard Bergman. But if the beta cell starts to fall behind and falls off that curve, that's when type 2 diabetes occurs. So this happens in a two-step process. In the first step, there's presumably both some genetics and acquired reasons why the patient may have insulin resistance. It could be lifestyle, obesity, and sedentary changes, or something related to genetics. As that insulin resistance progresses, a second hit has to happen at the level of the beta cell. That may be, again, some kind of a multi-genetic problem, or it could be related to things such as glucose toxicity or lipotoxicity, causing a decrease in beta cell function and subsequently resulted in diabetes. Now, the amount of weight that is required in order to change this equation is relatively small, and it depends on the ethnicity of the individuals. So, for instance, Asian Americans require very little increase in body weight in order to have a substantial increase in insulin resistance and be at increased risk for diabetes. In this graph from the Nurses' Health Study, a difference of only 5 kilograms above where their usual weight is was enough to promote them into the diabetic realm. And that changes by different ethnicities. Groups that are at particularly high risk, even with relatively small amounts of increased weight, would include Native Americans, Pacific Islanders, and individuals in our country and in Texas, such as Mexican Americans. Now, we know that lifestyle changes has a significant impact on reducing the rates of diabetes. This is from the diabetes prevention trial and the finished diabetes prevention trial, showing that intensive lifestyle changes related to weight loss, diet, exercise can drop the rates of diabetes in high-risk populations by as much as 60%. it is, of course, difficult to follow these recommendations. In addition, we are concerned about the genetics of diabetes, in particular type 2 diabetes, and it's clearly not a single gene disease. But there are some genes that we know have some impact on the development of diabetes. One of them is the transcription factor TCF7L2. And this is again from the diabetes prevention trial, looking at individuals on the top left that were randomized to the placebo group. And there you can see that if you do have that gene, your risk of diabetes is clearly higher. Right below that is the lifestyle intervention group. And you can see there that in this randomized trial, if lifestyle intervention is given, then the difference, the genetic contribution to this is voided. And so there was no difference between the two groups. So this is encouraging. It means that regardless of the genes that you have inherited, changes in your lifestyle can prevent and treat diabetes. Now, the amount of exercise you need to do is significant. This is from the STRIDE study, showing that in order just to stay where you are, to maintain a stable metabolic rate, the equivalent of about 12 miles per week of exercise needs to be done. This could be a variety of combinations. It could be walking fast, it could be running, but the equivalent of about 12 miles per week is necessary just for stability. This is from the STRIDE study showing that if you want to lose weight, if you want to change your lipids, you want to raise your HDL, then you need to do about 20 miles a week. This is codified in the recent ADA standards recommendations in terms of looking at the breakdown between weight loss and weight maintenance. And so using intensified counseling, diet, exercise will get the weight down. But then in order to maintain that weight, you may actually need to intensify the amount of exercise that you're doing, as noted in this slide. So is there a particular diet that is better than any others? Many studies have been done looking at a variety of different diets, and there really is none that is substantially better than any other, whether it be a low protein, a low carbohydrate, or a variety of different combinations. Only one diet seems to stand out in terms of cardiovascular benefits, and that's the so-called Mediterranean-style diet. Now, many people think when they hear the term Mediterranean-style diet that it just means eating a lot of olive oil. Well, it's actually a little bit more than that, and there are many things in the American diet that can be adjusted in order to achieve a score on the Mediterranean diet listing that would give good benefit in terms of cardiovascular health. And this is a score that was developed some years ago, looking at a 0 or 1 measurement on each of these qualifications. So how much vegetables you eat, whether you eat 4 or more servings per day. If you do, you get a 1. If you don't, you get a 0. And then you count these up in terms of number of legume servings, fruit, nuts and seeds, whole grains, fish, fats, alcohol, and red and processed meats. And if you're able to score 6 or higher, then there is a cardiovascular benefit, even if there is no change in your weight. And there are a variety of scoring ways to do this. So at home, you can give your patients this list, and they can run down that pretty quickly to be able to see whether they are scoring adequately or not. And if they're not, there are some simple ways of being able to make those changes. And this relatively small change in dietary intake does have a substantial impact on cardiovascular health. Looking at the weight loss programs that have been studied extensively, this is a graph looking at several of them. The top 3 are lifestyle intervention, the Look Ahead study, and the diabetes prevention program. And I'll go into a little bit more detail on the Look Ahead study in a second. But you can see that in terms of losing between 5 and 10% body weight, there's a reasonably good chance of being able to do that. And losing 5% body weight does have important metabolic consequences in terms of improving glucose control and cardiovascular health. So even though it seems like a fairly small amount of weight loss, especially to individuals who are significantly overweight, even a small amount of weight loss has a substantial impact. And I think this is important to emphasize to your patients because many of them may be 50 to 75 pounds overweight, and they're thinking that they need to get down that amount of weight in order to be able to get some benefit. For most of those individuals, the amount of weight that they would have to lose is somewhat unrealistic, whereas losing 5 to 10% body weight, as can be seen in these studies, is very realizable and will have important consequences. We now have a variety of medications that we can use as aids that are now approved for chronic use. And I've listed them right below, and you can see the differences between placebo, Orlistat, which is a fairly weak agent, lorcaserin, which has a pretty good safety record. Its benefit in terms of weight loss is a little bit less than the phentermine topiramate combination, but it has a much lower side effect profile. And so discussing with your patients what their symptoms are, what their comorbidities are, do they have hypertension, are they anxious? So some of these factors in terms of their individual metabolic parameters may help you decide on, with them, again in a shared decision making, which one of these agents might be better for them. Among these agents is liraglutide, and all of the Glp-1 agonists, as I'll talk about in a second, are related to weight loss. There are some newer ones that have just very recently come on the market that seem to be associated with a greater amount of weight loss. And of course, if the patient has diabetes, that may be an additional benefit for them. And so in our patients with diabetes who are interested in losing weight and also need better glucose control, a GLP-1 agonist may be a good choice for that. This is from the Look Ahead study. The Look Ahead study was an ambitious way of looking at the multi-center program to see if patients with type 2 diabetes who were overweight and were randomized to an intensive lifestyle change would also reduce their cardiovascular risks. And the results of this was somewhat disappointing because over the 11 or so years of the study, there was no substantial benefit in terms of cardiovascular disease, although there were many other benefits in terms of disability and blood pressure and other findings. But in terms of cardiovascular outcome, the study was stopped because of futility. And you can see from the results here on this graph why that may have been true. And like with many lifestyle intervention trials, they work initially, as can be seen in the upper left side, where there was a nice weight loss initially, but then there was some weight gain over the subsequent period of time. Interestingly, in the control group, because they also knew that it would be good for them to lose weight, so they also lost weight, which was not necessarily anticipated. And so the difference between the two, as you can see, was narrowed. To the right of that is their exercise component. And once again, you can see that initially there was an increase in exercise, but then it tended to drop off over time. Even with fairly intensive telephone recording, follow-up visits, etc., it's very hard to maintain that amount of exercise. Body weight went down, and glycohemoglobin in the bottom right showed a substantial improvement initially, but then gradually came back up towards their baseline. This is a cartoon from Ralph DeFranzo, again, showing all of the different organ contributions to hyperglycemia. As you can see, there are many different ways in which the body can both adjust to and suffer from some abnormalities in each of these different tissues. It also allows us to look at different targets so that different medications may be able to target each of these individual abnormalities. And so we now have many different medications for type 2 diabetes. I've characterized them into a variety of different groups and families. Some of the oldest ones, like metformin and sulfonylureas, remain very commonly used. Metformin has been the main first-line therapy for type 2 diabetes. It is inexpensive, it is generally well tolerated, and has a host of good benefits in terms of reducing insulin resistance and improving glucose metabolism, as well as some other potential benefits related to aging and other issues. The sulfonylureas, however, are associated with significant and sometimes severe hypoglycemia. And as I'll show you in the upcoming slides, they are no longer on the top of our list in terms of giving them to patients. They remain inexpensive, but weight gain remains an issue with them. And the only two groups of medications that are associated with both hypoglycemia and weight gain are sulfonylureas and insulin. And so if we're trying to prevent weight gain and promote weight loss, we're going to be looking at many of these other medications. The Glp-1 agonists, again, play a primary role in that, and I'll be talking some more about their actions. And coexisting with them are the DPP-4 inhibitors, which are somewhat weaker agents, but the GLP-1 agonists are injectables, although now they can be injected just once a week, which is a benefit. But the DPP-4 inhibitors are once-a-day pills, so they do have that convenience issue for the patient. Not as potent and fairly neutral in terms of weight loss. There are now combinations of insulin with GLP-1 agonists. This may be convenient for the patients because then each of these medications can be titrated together, and that can reduce some of the side effects and the need for increased insulin. The other new group of medications on the market now are the SGLT2 inhibitors. These lower the threshold for glucose loss in the urine and therefore also promote weight loss as well as better glucose control. So the biologic activities of the GLP-1 agonists, GLP-1 naturally occurs in the ileum. This becomes more important when we talk about bariatric surgery and how that impacts on glucose control. And it stimulates insulin secretion. It stimulates the insulin gene expression. It blocks glucagon. Again, another important hormone in glucose homeostasis. It slows down gastric emptying, giving the sense of fullness, and it has important neural effects as well. And so appetite is dropped, and most people will lose a substantial amount of weight at the same time as better control of their diabetes. So this is from the American Association College of Endocrinologists. This is the 2018 algorithm for deciding on how to implement the different medications. As you can see, for monotherapy, if the blood sugar is not all that high, with A1Cs being in the 7.5% or lower range, metformin remains the first-line therapy. If the patient is unable to tolerate metformin because of GI disturbances, then there is a list of other medications that can be tried, with the GLP-1 agonist now rising to the top. And you can see that the sulfonylureas down on the bottom with a caution sign regarding hypoglycemia. Also going down towards the bottom is the thiazolidinediones. Again, these medications have a variety of potential side effects, including weight gain, edema, and potential cardiovascular outcomes. They remain useful medications, but lower down the list, and as mentioned, they do not cause hypoglycemia. If the average A1C is rising, then a second agent needs to be added, looking at the different organs that contribute to the hyperglycemia. And again, metformin plus one of those other agents that I mentioned works very well together. If we're still not at the goal, an additional agent can be added or insulin can be added. But nowadays, we no longer switch over to insulin only, but continue to rely on adjunctive therapy with insulin. This helps to reduce the hypoglycemic risk of insulin as well as the weight gain associated with insulin. So a combination of insulin and metformin, insulin and GLP-1 agonists, insulin and SGLT2 inhibitors, or any combination of those becomes very viable and again reduces your need for insulin and maybe can get the patient off the insulin. And this is looking at adjustment of insulin dosing, adding on that even if the blood sugar is fairly high and you do need to start insulin, you can still use some of these other agents to reduce the need for it. Now, none of these medications are perfect. They all have a variety of different side effects. And so once again, you need to sit down with the patient and look at some shared decision making in terms of what are the costs of these medications, do they have issues in terms of taking an injectable, or do they have other contraindications? For instance, is there a cardiovascular concern, or maybe we want to use an agent that is more beneficial in terms of cardiovascular protection? Are there issues with bone loss, GI disturbance, etc.? And this is a table that tries to detail that. Now, luckily, over the last few years, we now have several medications that have demonstrated cardiovascular benefit. In particular, this is a recent meta-analysis looking at several different GLP-1 agonists and their impact on cardiovascular disease, all showing some improvement. In addition, in terms of the side effects, they look pretty good in terms of hypoglycemia, pancreatitis, or pancreatic cancer. These changes are pretty much around the reference line. And similar findings have been shown in terms of cardiovascular protection with the SGLT2 inhibitors. These medications can be added on to individuals who have failed usual therapy. So this is from the Qatar study, looking at individuals with an average A1C of 10% on maximum doses of sulfonylurea and metformin, our theoretical baseline medications. And they were randomized to have the addition of basal and bolus insulin or the addition of pioglitazone and exenatide once a week. And you can see that the addition of exenatide and pioglitazone made a dramatic drop in the A1C down into the 6% range, so better than with the addition of insulin, and at a lower cost in terms of weight gain. When you compare the GLP-1 agonist directly with insulin, this is a study looking at once-a-week exenatide versus daily glargine, you can see that you can arrive at the same A1C, but with the glargine you have weight gain, and with the exenatide you have weight loss. Similarly, you can add exenatide to the insulin, as well as adding a DPP-4 inhibitor to the insulin, in this case sitagliptin, and get beneficial effects. So you can lower the blood sugar without adding more insulin and again reducing your risk for hypoglycemia. This is a study looking at combination therapy of exenatide with glargine, and irregardless of what A1C you start with, what BMI you start with, how long you've had diabetes, the addition of the two together gives you improved glucose control with decreased weight. And this is from dapagliflozin, which is an SGLT2 inhibitor, showing fairly similar changes in terms of glucose corresponding with weight loss. Now, when we look at intensive lifestyle changes, as I showed you, you can arrive at the 5 to 10% range, but when you look at bariatric surgery, metabolic surgery, you see substantially higher rates of weight loss, as well as substantially higher rates of diabetes remission. And this is a comparison study looking at medical nutrition therapy, lifestyle intervention versus on the top one, laparoscopic banding, Next, below that, Roux-en Y, and below that, a comparison of sleeve gastrectomy and Roux-en-Y bariatric surgery. So as you can see, there's a substantial increase in weight loss corresponding with an improvement in blood sugar. This is a meta-analysis recently published looking at many different bariatric surgeries. And the interesting thing about this, as well as the STAMPEDE study, is that there was no difference whether the BMI was greater than 35 or less than 35. So we have the impression that only the people that are incredibly overweight will get benefit from this. In fact, many people who are barely above weight will get substantial benefit in terms of diabetes remission. And there are many formulas looking at what are the possible proportion of individuals who will have remission of their diabetes and be able to get off all or almost all of their medications with one of these metabolic surgeries. Now, why does this happen? Well, weight loss obviously is a major component to that, but we are rerouting the nutrients, and this affects the hormonal system. So as I mentioned before, GLP-1 is made in the distal ileum. And if we can get food down there quicker by using something like a gastric bypass, this will stimulate that hormone and will change the hormonal milieu. And so several hormones are related to this, PYY, GLP-1, a variety of other signaling mechanisms that may be important to that. We're also changing the microbiome, and so there is a lot still to be learned about the rerouting of these nutrients and how that impacts on diabetes, but many animal studies and human studies have shown the benefit of changing this route. So with this evidence and the evidence from the STAMPEDE trial, which was a randomized controlled trial looking at bariatric surgery compared to medical nutrition, showing significant reduction in diabetes, significant number of people being able to come off insulin with normal blood sugar control, has promoted the new recommendations in terms of medical care and metabolic surgery. And so the new recommendations relate to a BMI of greater than 40 or greater than 37.5 in Asian Americans, regardless of the level of glycemic control or complexity of glucose-lowering regimens, and to be considered if the blood sugar control is not within target for individuals greater than a BMI of 35 or 32.5 for Asian Americans. In addition, it should be considered for patients with type 2 diabetes at even lower BMIs, down to 30 or even 27.5 in Asian Americans. This relates to the fact that many Asian Americans and Asians around the world tend to accumulate more visceral fat at a lower BMI, resulting in a higher amount of insulin resistance and diabetes. Of course, these surgical procedures should be done in experienced centers, and this graph is from the Diabetes Surgical Summit, again showing a similar recommendation related to different levels of obesity and where bariatric surgery should be placed in that. Now, I think that all of this needs to be looked at as combination treatments from all of the things in our armamentarium. So diet, exercise, diabetes medications, obesity medications, and bariatric surgery should not be used in isolation, but each individual should be treated with the combination of those that gets the best results and avoids the complications of diabetes. And with that, I'd like to finish with a quote from Jackie Gleason saying that the second day of a diet is always easier than the first because by the second day you're off it. This is Philip Orlander from McGovern Medical School, University of Texas Health Science Center. Thank you.